Hi guys, welcome back to my channel. This is Omolo the Great. So we are going to talk about regulation of cardiac output. This is just one of the other series of our cardiac physiology discussions or lectures. So please remember to subscribe, to share and like this video. Alright, so what is cardiac output? Cardiac output is an important measure of heart function, okay? Because the big role of the heart is actually to pump blood, okay? So how can we evaluate how much blood the heart can pump, okay? Or the ability of the heart to pump this blood. So we can evaluate that by just understanding and knowing about the cardiac output. So cardiac output is actually the amount of blood that the heart is able to pump in 1 minute, okay? So cardiac output. So, and this cardiac output is expressed, can be expressed. This is going to be an important formula in our discussion. Can be expressed as the product of the stroke volume and the heart rate. Okay. So heart rate. Heart rate is just the number of beats made by the heart in just 1 minute. Okay. So this heart rate is measured in beats per minute, okay? Whereas the stroke volume is the volume of blood injected by each ventricle in 1 minute, okay? Rather in 1 beat. So stroke volume is the amount of blood injected by each ventricle in 1 beat, okay? So stroke volume is, so it will be how much mils are you ejecting out of the ventricle in 1 beat, okay? So what happens, so this, of course, this can just cancel out beats and beats. So what do we get? This becomes mils per minute. Mils per minute, okay? So the total amount of blood pumped by the heart in 1 minute is what we refer to as the cardiac output. So simply put, cardiac output, volume of amount of blood pumped by the heart in 1 minute. Stroke volume, volume of blood pumped by each ventricle in 1 beat, and the heart rate, number of beats made by the heart minute. Okay, so the regulation of this cardiac output can be regulated. I've tried to simplify it in some way. Can be regulated in 2 ways. Okay, so the regulation can be done in 2 ways. We have let me put it here. The regulation of cardiac output can be done in 2 ways. Can be done in, we have what we call intrinsic mechanisms, okay? We also have what we call extrinsic mechanisms, okay? So under the intrinsic mechanisms, these ones we have what we call, one is what we call the Frank-Starling mechanism. We have what we call the Frank-Starling mechanism, okay? And then 2, we have what we call the Bainbridge mechanism or reflex. The Bainbridge reflex, okay, or mechanism, okay? So under the extrinsic, we can have, these ones are quite many. One, we can have, there's a role of the autonomic nervous system. So the ANS, the autonomic nervous system, okay, which we know is comprised of the sympathetic nervous system and the parasympathetic nervous system, okay. 2, we have a role of ions. Different ions can actually modulate the ability or the ability of the heart to pump this blood in a minute, okay. So we have the role of ions, okay, and here most commonly we have a lot of an influence by the calcium ions and also the potassium ions, okay. And then we have there's a role of temperature. Temperature, changes in your temperature can actually affect your cardiac output, okay. But also we have an input from some hormones, okay. We shall be seeing some hormones, especially the thyroid hormones, okay. That is T3, T4, and then also there's a role we can see like epinephrine, okay, which is produced from the adrenomedulla. Then we can also see some other physiological variations that bring about can also regulate or bring changes in our cardiac output. some physiological variations. We have what we call age. Okay, so age can bring about changes in your cardiac output, whereby when you're young, as a neonate, your cardiac output will be different from that of an adult, and even when you grow old. And then also we have what we call the sex. Okay, so we also have an input of, for example, exercise. So if you do physiologically, if you do exercise, this will also bring about changes in your cardiac output. So this is the concept. So if you have these things at the back of your mind, you can always explain how normally the heart undergoes changes, especially how cardiac output or cardiac function is actually regulated or modulated. So let's start by discussing the Frank-Starling mechanism, okay, or the intrinsic mechanisms first. So when we look at, let's look at the intrinsic mechanisms. Intrinsic mechanisms, okay. And the first here we shall look at the Frank-Starling mechanism, okay. So if you look at the Frank-Starling mechanism, okay. So if I have my heart here, okay, we just draw a small illustration here. This is our pulmonary veins, and then obviously we have our descending, we have our superior and inferior vena cava, and then we have our right and left ventricles. Okay, so this will help me explain some changes. So what does Frank-Starling mechanism refer to? It states that within physiological limits, the heart pumps all the blood that returns to it by way of veins. Okay, all the blood that returns to the heart. Okay, so the heart has a venous system that receives the blood or gains the blood from all the blood returning to it. Okay, here in this case we are talking of this blood that's coming from the superior vena cava, from the inferior vena cava, and returning to the right atrium. Okay, we also have blood that may return, okay, to the coronary sinus, but we also have blood returning, okay, to the left side from the lungs, okay, to the pulmonary vein. So, but remember the total proportion. If you look at pulmonary and systemic circulation accounts for about 84% of all the blood volume that is in circulation. So it has, which means to make up a big component of the venous return. This is the concept I'm trying to introduce, the venous return, implying that all the blood, the biggest proportion or contribution of venous return will actually be coming from this right side, okay? All the blood returning to the body, okay, or returning to the heart from the body will come to the right side, okay? Obviously pumped to the lungs and then channeled back to the what? To the left side through the pulmonary vein. So you see there's a big proportion of this blood that is returning. So the venous return is actually affected by several things. So Frank-Starling stresses the point that all the blood, the amount of blood that comes into the heart, okay, will affect how much the ventricles will fill with. So it will affect the end diastolic volume, okay. So if the venous return is actually high, then the end diastolic volume also increases. When the end diastolic volume increases, definitely the stroke volume is also going to increase. And if you increase the stroke volume, okay, from here, you realize it's because stroke volume is direct proportion to the cardiac output. Cardiac output will actually do what? Will also increase, okay? So this is the concept of Frank-Starling, in that when the anything that bring about an increase in the venous return will increase the end diastolic volume, increase the systolic, the stroke volume, and eventually will increase the cardiac output. But let's try and look at this in details. So you realize that from the Frank-Starling mechanism or the Frank-Starling law, okay, so the biggest change we are affecting is the stroke volume, okay, from what I've discussed, the stroke volume, and it's the stroke volume that directly affect the cardiac output. So we can actually see some factors and see, which means that some things, if anything is going to modulate the stroke volume, will directly modulate the cardiac output. So what are some of those factors, okay, that will affect the stroke volume, okay? So the first thing, stroke volume will be affected by what we call the end diastolic volume, okay? But broadly, we can put them together. One, we can say is affected by what we call the preload, okay? Two, the contractility of the heart, okay? And then three is actually the afterload, okay? So these three factors actually affect and play a big role to affect the stroke volume. So this preload, let's look at preload. What is this preload and what does it mean, okay? So this preload is basically what we may call like the stretch, okay? So it's usually the volume dependent strength that is required to build, to eject this volume of blood, okay? So the stretch created by the increase in volume is what we call this preload, okay? So if you call it just like a stretch, so preload to be a stretch that is exerted by these changes in the volume, especially the end diastolic volume. So implying that the end diastolic volume is the biggest determinant of the preload, okay? So this can be affected by several things. So the end diastolic volume is determined by one, the stretch of the ventricular wall or muscle wall. One, it will depend on how much volume is coming to it, okay? So the amount of volume of blood that is coming to the ventricle or filling during diastole is actually determined by the venous return, okay? So this is largely determined by what we call the venous return. So venous return plays a very big input, okay? So venous return. And what are some of the things that affect? So you see, we are trying to backtrack it to see which factors will actually bring about the changes in the stroke volume. So which factors will affect the return of blood, okay, to the heart? So this return of venous blood. One, we have what we call the blood volume, okay? So the blood volume. So the volume of blood that is within this venous system, okay? The volume of blood that is within this venous system will largely affect how much blood will return to the heart. So in cases, if you give a patient a transfusion, this implies that you're increasing the volume of blood. When you increase the volume of blood, this increase in the volume of blood will actually exert a bigger pressure. So there's usually, remember, blood flow will move from a higher pressure to an area of lower pressure, okay? So from the venous system, where we have what we call the central venous pressure, okay? Within, we have the arterial, the capillary, okay? And then we get the venules and then the venous system. So the central venous pressure that is literally is determined so much by the blood volume. This central venous pressure, okay, is compared to the pressure in the right atrium. So the right atrial pressure. So the difference between the central venous pressure and the right arterial pressure is what we call the pressure that is required to cause this venous return. Is what we call the mean systemic filling pressure, or what we call the mean circulatory pressure, okay? So this pressure is determined. So the increase in this blood volume will increase the central venous pressure. If you increase the central venous pressure, which means if you have a value of initially maybe 10, okay, the pressure in the right atrium is usually low, maybe around 5, maximally to 7 millimeters of mercury. So you get a gradient if we take maybe 7, okay, or even less, sometimes even negative to 2 millimeters, even to negative, okay. So if you take, let's take plus 2, so the gradient is about, rather plus 3. This means the pressure is usually around 7 millimeters of mercury. So this is the pressure gradient required to push this blood from this side, from the pooling within the venous ends up to the right atrium. So you see the second blood volume affects, and then 2, we have what we call the mean systemic filling pressure. This one also largely affects the venous return. So the higher the mean systemic filling pressure, the higher will be the venous return. Okay. So, but we have other things. Okay. We have what we call a muscle pump. Okay. And then we have what we call a respiratory pump. Okay. So usually these veins, okay, remember these veins have some valves which prevent backflow of blood. So as venous blood is moving, usually as you move, as you do some movement, okay, or walking, or so this contraction of these muscles, okay, exerts a compression pressure onto the venous, these veins, okay. So it exerts a compression pressure onto these veins. It causing blood to actually move, or aiding what we call the venous return, and that is the muscle pump. Okay, contraction of the muscles will compress the vessels to aid blood to move in one direction due to the presence of valves. But also we have what we call the respiratory pump. So look here, when I am breathing in and out, when I breathe in, okay, so my chest expands, so which means the volume of my chest cavity actually increases. But what happens with the pressure in the chest cavity? Pressure falls. So whereas the volume, whereas the pressure in the abdominal cavity actually builds up. Okay, so you have pressure in the abdomen. Okay, and then you have pressure in the chest. Okay, so the pressures here, because of the increase in the cavity, intrathoracic cavity, the pressures actually fall. Whereas here the abdominal pressures are what? The abdominal pressure is actually increasing. So blood has to move back from here up to there. So you get sort of a suction pressure, okay? Blood is being suctioned from the lower ends back into the chest. So this allows venous return. So that is the big role and contribution of the respiratory pump. But we also have another contribution. We have what we call the venomotor tone, okay? So this venomotor tone is about the smooth muscle, or venoconstriction. Venoconstriction is about the activity of the sympathetics onto the smooth muscle wall of the vessels. So sympathetic innervation causes contraction of this smooth muscle wall, thereby aiding venous return. So that is also very, very important. So these factors can actually aid, venous return. The other thing that can actually affect end diastolic volume, one is the venous return, two is actually what we call the filling time. Okay, so the filling time. So the longer, okay, or the higher the filling time, okay, or the more time you spend in diastole, the more you're allowing the heart to actually fill. Okay, so you'll be increasing the end diastolic volume. Okay, so eventually if you increase the end diastolic volume, you're going to increase the systolic volume and eventually increase the cardiac output. Okay, so under circumstances where your heart rate is actually very high, okay, this heart rate actually causes the reverse. It will decrease the filling time, eventually decreasing the end diastolic volume, and then the same picture happens, decrease stroke volume and also the cardiac output. So you need to allow when you have, for example, tachycardia, okay, so this will get an increase in the heart rate and cause a decrease in the cardiac output following this pathway. But also, because we say this is a stretch, okay, the preload, so implying that also the health of the heart, okay, so the health of the heart is also very, very important, because in patients who have like myocardial infarction, it is they usually get fibrous tissue, that is the myocardium, it becomes more fibrous. So the more fibrous the myocardium becomes, the harder it is to stretch. So irrespective of the volume changes, these ventricles or muscles are not compliant. So you find in cases like a myocardial infarction, you find you get a decrease in the end diastolic volume, and eventually this will also decrease the stroke volume and eventually decrease the cardiac output. So far you see that actually in conclusion, the preload, okay, what does the preload do to the stroke volume? So when you have an increase, okay, let me use black. When you have an increase in the preload, okay, this causes an increase in the stroke volume, and eventually this will cause an increase in the cardiac what? Output. So that is one important factor. Let's look at the second factor, okay? Let's look at the second factor, which is contractility of the heart. So we look at the contractility of the heart. Contractility of the heart, okay? So we want to see how this will actually affect the stroke volume, okay? So this can be affected. One, we have what we call the sympathetic nervous system, okay? So the sympathetic nervous system largely controls this contractility of the heart. The sympathetic obviously will release neurotransmitters, especially we have the norepinephrine, okay? Norepinephrine works through the GS, increasing cyclic AMP, okay? Increasing cyclic AMP, and obviously will result into increased firing or heart rate, okay? So increase the ability of the heart to do what? To contract. So electrical changes, depolarization will bring about more of what? More of the contraction. So the increase of sympathetic activity will actually increase the contractility of the muscle, and eventually that will increase the ejection ability, okay? So when you contract the ventricles much more strongly, which means you're going to be able to eject a good volume of blood, which is the stroke volume. And the increase in the stroke volume obviously will increase the cardiac output. Also, we have an input of hormones, okay? So hormones, for example, we have the epinephrine, okay, which is produced from the adrenal medulla, which will also give us sympathetic activity results, increasing contractility. But also you have what we call the T3 and T4, which are the thyroid hormones. These ones increase the expression or the production of the beta-1 adrenergic receptors. So beta-1 adrenergic receptors, these are the receptors through which the norepinephrine works. So norepinephrine, which is also from the sympathetic, works by binding on the beta-1 receptors found within the cardiac muscle and also in the sinoatrial node, okay? So binds on beta-1, and then through the GS increases cyclic AMP, obviously the same pathway, then you get an increase in actually the contractility of the heart. So beta-1 is increased expression of beta-1 and also brings about a sympathetic effect, okay? So this is how, so when you increase contractility, you're actually going to increase, okay? You're going to increase the stroke volume, okay? When you increase the stroke volume, eventually increase the cardiac what? Output. Yeah. Then the last bit of is actually the afterload. So the other factor is afterload, okay? So when you look at the afterload, so what happens with the afterload? Afterload, this is, you see, after the heart here, for example, from the aorta. The aorta usually needs to pump this blood from, the blood pumped to the aorta from the ventricles, okay? So the pressures, usually the pressure from our discussion on cardiac cycle, you see the heart has to build the pressure to overcome the normal pressure of the aorta around, which is around 80 millimeters of mercury. So it needs to pump a pressure higher than this, so it can pump this blood in that direction, because blood will move from lower pressure to a higher pressure, okay? Rather, will move from a higher pressure to a lower pressure. So from the heart ventricle will build a much higher pressure, okay, which will overcome this pressure, so blood can move in that direction. But because of the arterial system, which has the smooth muscle walls, okay, these smooth muscle walls, this arterial system can actually exert a resistance. So if you increase the resistance to blood flow here, which means you need a much higher pressure built here to overcome the resistance. And so this resistance to blood flow, okay, resistant to ejection of blood, is what we refer to as the afterload. So this is just the resistance to ventricular what? Ejection, okay? So this is usually sort of the pressure built or resistance offered. It could be resulting from some things. One, you could have a vessels. Maybe those vessels actually, the diameter has decreased because of atherosclerosis, okay? because of atherosclerosis, where you have a vessel, okay, and then you get atherosclerotic plaques, okay, that occlude the aperture. So they decrease the aperture, okay, of this vessel. So blood needs to pass through this small aperture with a much higher pressure. So the source, the pump, has to build a much higher pressure to overcome this obstruction. So this is one case. Also, in cases of hypertension, so this is also very common, okay? So you find hypertension, the total peripheral resistance is very high, so the heart also has to pump a lot of, to build a lot of pressure to pump blood against that, okay? So if the afterload is actually very high, the resistance is very high, okay? And the heart is not able to mount all this pressure, all this force to overcome that, which means the amount of stroke volume or blood ejected, okay, per beat is going to be affected. So increase, implying that when you increase the afterload, you actually decrease the stroke volume, because you're decreasing, the resistance is higher. So the resistance to ejection is very high. So the volume ejected by the heart in a beat is decreased. And when you decrease stroke volume, eventually you decrease the cardiac output, okay? So to summarize these factors from here, the Frank study, you see that when you increase the preload, stroke volume actually increases and the cardiac output also increases. Even contractility, when you increase contractility, okay, you're going to increase the stroke volume, eventually the cardiac output increases. However, it is the reverse for afterload. If you increase the afterload, the resistance to flow, actually to ejection of the ventricles, stroke volume actually decreases, eventually your cardiac output will also what? Will also decrease. So this is about, this is how the Frank-Starling mechanism actually works. So now we've done with the Frank-Starling mechanism. Let's look at the Bainbridge reflex or mechanism, okay? So this also plays an intrinsic role regulating the cardiac output. So Bainbridge reflex, they are volume receptors that are found within the atria, especially on the right side, when that detect changes in volume in the venous return. So any fall in the volume, okay, of the venous return will send impulses to the nucleus tractus solitarius, okay, within the brain, and this brings about especially found within the impulses will reach especially the cardio-acceleratory center. What does this cardio-acceleratory center do? It's going to fire impulses that are going to return to this, atrial node, okay, and then they will cause to increase the heart rate, okay. And when you increase the heart rate from our formula, when you increase heart rate is direct proportion to cardiac output. When you increase the heart rate, you actually increase cardiac output. So this is simply the Bainbridge reflex. Right, and now the last bit is actually the extrinsic pathway, okay, or the extrinsic mechanisms. We have an interplay of different. Let's look at the autonomic nervous system, which is our first. We said autonomic nervous system is comprised of the sympathetic nervous system and the parasympathetic nervous system. Okay, so if you look at, if this is our heart, okay, this is our heart, we have the sympathetic trunk, okay, the sympathetic innervation, the sympathetic nerves that come, okay, and then they send their nerves to the what? To the heart, okay, and then we have what we call also the parasympathetic that come through the vagus nerve. They'll literally go primarily, you see, they'll innervate, they'll run most distributed around the AV node and the sun and the AV node, okay, and then the rest, these are the sympathetic nerves. So these have different effects. Simply put, the sympathetic nervous system will result into an increase in the heart rate. So you realize most of our discussion in the intrinsic pathways, they bring about changes in the stroke volume, okay, especially when we're talking about the Frank-Starling mechanism. And then the Bainbridge reflex, we saw it is bring about a lot of changes in the heart rate that then will result into changes in the cardiac output. So let's see extrinsic. Some of them are actually going to be modulating a lot of the stroke, the heart rate. So the sympathetic nervous system, so impulses that are coming through the sympathetic nervous system, we have receptors, okay? There are receptors on the myocardium and also on the conductive system, especially the sun. And those are beta-1 adrenergic receptors, okay? These beta-1 adrenergic receptors of the sympathetic, okay? They release what we call norepinephrine as a neurotransmitter, okay? So norepinephrine that is released usually results through the GS, okay, through the binds to these beta-1 receptors through the, which is the GS receptors, okay, increasing the cyclic AMP activity. And this obviously will result, eventually brings about phosphorylation of channels, opening of channels, and then we get a depolarization. So increased activity of the sympathetic nervous system will increase the depolarization of the sinoatrial node. Okay, so remember that to visit the action potential of the sinoatrial node, a link that I've already shot a video on that, and the link is in our description box. So that is the sympathetic. So sympathetic will result into an increase in the heart rate. Okay, whereas the parasympathetic nervous system, for it instead produces acetylcholine. Acetylcholine, its postganglionic fibers will bind to the M2 receptors, all these muscarinic receptors, and especially on the myocardium, and these result into depression. Okay, so for them they'll work through the GI, resulting to a decrease in the cyclic AMP, and eventually they will decrease the heart rate. So if you give even drugs that are sympathomimetics will tend to increase your heart rate, and drugs that drugs that are parasympathomimetics, they can actually have a negative effect on your heart rate. But if you block the parasympathetic, then you actually be able to have an increase in the heart rate. So that's the interplay with actually drugs. They just interplay with this mechanism. Okay, so this is the autonomic nervous system. This is how it modulates the heart rate. And you know, if you increase heart rate, you increase cardiac output. Decrease heart rate, decrease cardiac output. Second parameter, or second extrinsic factor, is actually what we call the ions. Let's look at the ions. The ions. First we look at the calcium ions. Okay. So when you increase states of hypercalcemia, when you increase the calcium ions, increase in calcium ions, you know calcium is an important ion in the contraction or the contractility of the cardiac muscle of the heart. Okay. So increase and also calcium is important, as I already told you, in the depolarization of the sinoatrial node, or generation of the pacemaker potential of the sinoatrial node. So increase in the amount of calcium will definitely result into an increase in actually the heart rate. Okay, so eventually this is it brings about positive effects in the heart rate. Okay, then a decrease in the calcium. If you decrease calcium levels, obviously it will decrease the heart rate, and the changes in the heart rate will directly affect the changes in the cardiac output. 2, potassium. Okay, so what happens with potassium? When you increase amount of potassium, okay, what is going to happen? Okay, increase in potassium actually slows the heart rate, depresses the heart rate. Whereas when you decrease the amount of potassium, it actually increases the heart rate. And an increase in the heart rate will increase cardiac output. Decrease in the heart rate will decrease cardiac output. So in these states of hyperkalemia, okay, these patients actually, because of depressed heart rate, they can get into a cardiac arrest. Whereas excessive activity following a hypokalemia, when you have low potassium, this is called hypokalemia. Excessive activity of the heart following a hypokalemia due to increased heart rate can actually give you an arrhythmia. Okay, so this really occur. To put things in perspective, when we have, this is the cell, okay, when you have the cell, under normal circumstances, our cells have what we call a sodium-potassium pump, which pumps 3 sodium out and then pumps 2 potassium inside. Okay. two potassium inside, and then obviously we'll have leakage channels, okay, which will help to establish our resting membrane state as we've been talking about. Okay, so what happens if I increase the concentration of potassium outside the cell? Okay, so too much potassium here, because this channel, if you look at the functionality of the sodium potassium pump, it has binding sites. So it has the two active sites or binding sites for potassium outside, and three binding sites for sodium inside. So this channel can only be activated after these active sites are actually occupied. Okay, so when you have a lot of potassium outside, because this channel needs potassium to work, it's going to be actually excited. Okay, all the activity is actually that is increased. Okay, so when you increase the activity of this sodium potassium pump, what is the eventual result? It is eventually pumping a lot of sodium outside. Okay, and then the amount of potassium that is being pumped, potassium is recycled. Okay, so the net effect, one, you're going to see if you look at the volume of the cell is going to decrease, because sodium is being pumped out. Where sodium goes, water follows. So the cells actually become flaccid. Okay, but also because the cells are flaccid and there's a lot of sodium that has been pumped out of the cell, the net charge within the cell, because of a lot of positive ions that are pumped outside, 3 to 2, and these two are actually constantly channeled out. So a lot of positive ions are channeled out. You find the cell negative charge, the cell membrane potential becomes more electronegative. And the more electronegative, the lower the excitability, or the lower the ability to generate an action potential. And that is why we get a depression in the heart rate. Okay, so that's what happens with this. Okay, so very much depression in heart rate will actually give you cardiac arrest. Whereas when the reverse happens when we decrease the amount of potassium outside the cell, instead of hypokalemia, decrease amount of potassium outside the cell, what does it cause? It will actually, because less amount of potassium is outside, so the pump becomes inactive. Remember, we said it's only active when when the channel has bound 2 potassium outside and 3 sodium inside. So if it binds 3 sodium and then no potassium is binding outside, the pump is actually inactivated, or it's inhibited. So because of inhibition, what happens? No sodium is moving out. Okay, the little potassium is actually leaking out to restore the membrane to try and restore the depletion or the low levels of potassium outside. Eventually, the sodium that is remaining within the cell will turn the membrane to become more electropositive. Okay, so if you look at the volume state of the cells, where sodium is, actually water follows. So the cells tend to engorge or to enlarge, or they become turgid. And then the heart rate, because of the increase in the positive ions, the membrane potential is going to change from negative towards positivity. And as membrane potentials change towards positivity, they actually get depolarized or become easier to depolarize. And that is why the heart rate actually does what? Increases, because of increased several action potentials that are generated. So that is it about the ions. Let's look at temperature. 3 here, temperature. Okay, so temperature, when you increase temperature, okay, increase in temperature, what does it cause? Increased temperature will increase, the temperature, minimally or elevated temperatures are important for metabolic activity. So you're going to have an increase based on metabolic activity of the cells. When the metabolic activity of the cells has increased, what happens? You're going to have a lot of synthesis of ATP. Okay, so a lot of ATP is important in muscle contraction. Okay, so this is going to increase the contractility. Okay, and also increase the activity of increase contractility, and that will increase the stroke volume. Okay, contractility increases stroke volume and eventually increases cardiac output. But also this increase in temperature, remember we have the membrane of cells. Okay, it is a bilayer, which is a lipid bilayer, and the fluidity of the membrane is established by the presence of cholesterol. So because of increased temperature, this increases the fluidity of the membrane. Okay, so actually the membrane is said to become more permeable to ions. So the membrane is more permeable to ions. You're going to have more influx of positive ions within the cell, okay, and that causes increased excitation or generation of action potentials, and that will cause an increase in the heart rate, okay. So that will also cause an increase in the heart rate. Yes, because of increase in the membrane permeability, okay. Then when you look at the hormones, we have epinephrine, okay. Epinephrine, what does it do? Epinephrine, when it binds to the beta-1 receptors within the heart, obviously it's also going to work to give a sympathetic nervous system effect, okay, which is to increase the heart rate, okay. And epinephrine is produced from the adrenal medulla. Then the other hormones, the thyroid hormones, okay, where we have T3 and T4. These hormones, what do they do? One, they do something. They increase the basal metabolic rate. So when they increase the basal metabolic rate, okay, obviously increasing the basal metabolic rate will generate heat, and this gives us a similar effect. Generating heat will increase basal metabolic rate, increasing enzyme activity, ATP generation, and then obviously we're going to have contractility and heart rate stroke volume goes high, okay. But also stroke volume goes high. When stroke volume increases, you have increase in cardiac output. But also, when you have these hormones, they also increase the expression of beta-1 adrenergic receptors, okay, within this muscle tissue, okay, or within the heart. And increased beta-1 receptor, which means the tissue becomes more responsive to effects of epinephrine and also sympathetic nervous system. So eventually you have an increased effect of the sympathetic nervous system, and this increase of that activity will increase the heart rate. Increase in heart rate will increase the cardiac output. And then finally, physiological changes, okay? Normal physiological changes, things that bring about physiological variations that may contribute to changes in cardiac output. One we say is exercise, okay? So when you're exercising, what happens? The rate of metabolism is quite high, temperatures have increased. You realize we're getting back to this, okay? Increase in temperatures, increased basal metabolic rate will increase this ATP and bring about this increase in a stroke volume, and then contractility, stroke volume, and then you get increase in cardiac output. But also increase in temperature during exercise will increase permeability, and then increase depolarization, increase in the heart rate, and then eventually increase the cardiac output, okay? So that is exercise. And then for the age, okay, so there are variations. You find me and you, depending on the age group, we may actually have different heart rates. For example, when you have an infant, okay, or a neonate, okay, these ones have a much higher heart rate, which is around 120 to 140 beats per minute, okay. So the higher the heart rate, which means obviously the cardiac output will be much higher. Then when you have, for example, an adult usually range between a 60 to 80 beats per minute, okay. But these can be different. For example, if you say in males, okay, adult males and adult females. Adult males have a little lower heart rate compared to females. Females will have a heart rate of around 72 to 80 beats per minute, whereas male will have about 74 to maybe 75 beats per minute. So you see the heart rate in males is actually a little lower than the heart rate in females, okay? And then when you grow old age, okay? So this is 1, 2, then old, okay? When you grow old, so these persons actually tend to have a little slightly elevated heart rate, okay? And that increases mainly more of their cardiac output. So this is the summary, and this brings us to the end of our discussion on regulation of cardiac output. Remember the intrinsic, extrinsic, Frank Starling and Bainbridge effects for intrinsic, and the different factors that are under the extrinsic pathway. Please don't forget to share. Remember to subscribe, hit that subscription button, and also share this video. Don't forget to comment and ask any questions within our comment box. Thank you.